I'm going to present a description of the 10th Ebola epidemic in DRC. I will focus in particular on the epidemic control indicators and how they evolved over time. The 10th Ebola epidemic that occurred in the DRC since 1976, when the virus was first discovered. It was the second largest epidemic ever observed after the West Africa epidemic in 2013-2016. The strain was the Ebola Zaire strain. The epidemic lasted from July 2019 to June 2020 and affected the eastern provinces of North Kivu, South Kivu, and Ituri. It is important to note that it's the first Ebola epidemic where vaccines and investigational treatments were deployed at large scale. I have three objectives in this presentation: to describe the epidemic in terms of person, place, and time, to highlight the changes over time of the indicators of epidemic controls and management, and to identify risk factors for death. First, the case definition, which were used by the surveillance system and applied to operations. A suspected was any person alive or dead in the declared epidemic area that presented a sudden onset of fever with at least 3 of the aspecific symptoms listed here, or any person with unexplained hemorrhage or who died suddenly for an unexplained reason. Suspected cases were to be admitted to an Ebola health facility for PCR testing. A confirmed case was a suspected case with a positive Ebola PCR laboratory test. There was also a definition of probable cases that was applied only to suspected deaths. A probable case was a suspected case who died with the notion of having been in contact with a confirmed or probable case, but for whom PCR testing was not possible or not available. Data used in this analysis are the line lists of the Ministry of Health and the compiled line lists from the 42 Ebola health facilities. We also use vaccination data that were compiled by the Ebola National Commission. Descriptive analysis, we use lowest smoothing for presenting the trends of the indicators and a Cox multivariate regression model to identify risk factors for death. Here is a summary table of the epidemic. In total, 3,463 Ebola confirmed and probable cases were notified. Of them, 2,262 died, which give a naive case fatality of 65%. Half of deaths occurred in the community. 171 cases and 75 deaths were among healthcare personnel. The median age of cases was 26 years, and the male-female ratio was 0.75. These two values were very similar for cases who died. 528 cases, which is 15% of the total cases, were children under 5 years of age. 419 of them died, which give a case fatality of 79%. I will elaborate on this finding later in the presentation. This is the epidemic curve of the entire epidemic. A first peak occurred from October to December 2019, and a second and higher peak occurred between April and July 2019, followed by a steady and rapid decrease until October, but it then took 6 more months, with some bumps along the way, to record the very last case. North Kivu was the most affected province overall. These two maps present more details of the geographical distribution of cases. The highest number of cases, the map on the left, was reported in Beni and Katwa health zone, both in North Kivu province. However, in terms of cumulative incidence per population, the map on the right, the most affected health zone were Mabalako in North Kivu province, where the epidemic originated, and the neighboring zone of Mandi in Ituri province, with more than 200 cases per 100,000 inhabitants. start with the epidemic control indicator. The first indicator is the number of patients admitted and the proportion of confirmed Ebola positive. In total, more than 60,000 patients classified as suspected cases were admitted and tested in an Ebola health facility. 2,294% were confirmed Ebola positive. The vast majority, 96%, tested Ebola negative and suffered from another illness. The graphic show the evolution over time of this indicator. A couple of months after the start of the epidemic, there was a steady increase in the number of admissions until November 2019. Of note, the number of admissions kept increasing at the same pace for several months, despite the decreasing prevalence of confirmed cases after the second peak from April to July 2018. The second indicator is the number of community deaths. The 1,149 community deaths correspond to 51% of all deaths. The proportion of community deaths remained at around 50% for 8 months, and it started to decrease only in April 2019. The downward trend reversed at the end of the epidemic due to 2 community deaths among the last few cases. To continue with community death, we look at this indicator in children under 5 years of age. As I previously said, 15% of confirmed probable cases were children under 5 years of age, with a case fatality of 79%. Community deaths accounted for 65% of all deaths in this age category, a proportion much higher than in all other categories, and that remain much higher throughout the entire epidemic. Regarding the case known as a contact of an Ebola case, overall, 47% of cases were known as a contact and of an Ebola case, and 57% of them were also followed. The proportion of cases known as a contact, and in parallel, the proportion of cases known and followed was low at the beginning of the epidemic, and it gradually increased over time. Of note, the increase was constant even during the second peak of the epidemic. However, for the first 8 months, it was below 50%. Here we present the proportion of cases that were vaccinated. Overall, 80% of confirmed and probable cases were vaccinated. This indicator also improved very slowly over time, and there was a clear acceleration only from June 2019, during the second and major peak of the epidemic. Here, a second indicator related to vaccination, the ratio of person vaccinated. In total, slightly more than 300,000 people were vaccinated. That gives an overall ratio of 88 persons vaccinated per case. The ratio over time had a downward trend until August 2019, after the second major peak. Then from August 2019, there was a marked increase toward the end of the epidemic. Another epidemic control indicator, the delay from symptom onset to notification. This indicator is particularly important because a shorter delay allows a case to access treatment sooner and also reduce the chance of infecting other people. For community death, the median delay was 8 days and, as expected, did not change over time. For cases admitted on to an Ebola health facility, the median delay was 5 days. It fluctuated around 5 days to several months, and then started decreasing only from June-July 2018. A last indicator concerns case management, the case fatality among admitted confirmed cases. The overall case fatality was 49%. It fluctuated around 50% until July 2019, over 1 year from the start of the epidemic, when a steady decrease was observed from August 2019 to the end of the epidemic. The case fatality was 44%. Slide of results show the multivariate hazard ratio analysis for the risk of death of Ebola confirmed cases. At the Scientific Day last year, we presented a preliminary analysis data available at that time. Now that the epidemic has ended, we repeated the same analysis with the data from the entire epidemic. The findings were the same. The strongest factor for risk of death remained a low cycle threshold with an adjusted odds ratio of almost 6. A longer delay from symptoms onset to admission was also associated with a higher risk of dying. Risk of death was 2 times higher at more than 5 days delay. Investigational treatments were strongly associated with a lower risk of death, with a reduction of 40 to 90%. These findings with case under the Meury protocol were confirmed by the PALM clinical trial. And vaccination was also associated with a lower risk of death among almost half. Control indicators were poor, some of them very poor in the initial months from the start of the epidemic. Some indicators slowly improved over the course of the epidemic. Other key indicators, however, such as the proportion of community deaths and the delay from symptom onset to admission, did not improve for almost 1 year. This is despite the active case finding and very sensitive suspect case definitions that were used. Some fatality remain high. Case fatality remain high, though it was lower than in previous epidemics in the DRC. Case fatality was lower among cases who arrived earlier to the Ebola health facility, cases who were treated with monoclonal therapies, and cases who were vaccinated. Nevertheless, the long period with a high proportion of cases that were unknown contact and deaths in the community and the long delay from symptom onset to admission compromise the potential benefit of newly available vaccine and treatment. More efficient case identification and also a community-based surveillance are needed. We need to design or modify strategies and tools that are at the same time feasible for the Ebola response teams and acceptable for the population.